Hi there, I'm the neuromuscular mechanic, and today we're going to talk about ultrasound-guided intra-articular knee injections. So what can these be used for? So the general indication would be for knee arthritis, whether that's osteoarthritis, rheumatoid arthritis, for symptomatic treatment. And it can be both injections as well as aspiration. So with any injection that I do, I go through a checklist. What's the ideal patient position? What transducer should I use? Where should I put my probe to start using surface localization? And what structures do I need to know on my pre-scan to avoid? And how to identify my target? So we'll go through this. With patient positioning, I will have the patients on their back in a supine position with the knee flexed to 30 degrees, either with a towel or a bolster under their knee. And this 30-degree angle is felt to be the optimal angle to identify the suprapatellar recess on ultrasound, particularly if there's an effusion. It's felt to redistribute that effusion to the suprapatellar recess. So with the next part, with the transducer, I'll use a high-frequency linear ultrasound probe to get the best resolution. This injection isn't that deep, so I don't need to use a curvilinear probe. Then with surface localization, as I've alluded to, this injection is to the suprapatellar recess. So I need to be above the patella. So I take my ultrasound probe, put it in long axis with the distal aspect of the probe on the patella. From there, I will identify the suprapatellar recess, which we'll go over later in this video series, and then I'll rotate 90 degrees to short axis because I don't want to use the long axis view. I don't want to go through the quadriceps tendon with the long axis view. And it's easiest to identify the recess when an effusion is present, but we'll go through how to identify it even if it's not. Then, with our pre-scan, structures that are important, again, patella, because it's a suprapatellar recess that we're going after, the femur, the quadriceps tendon, which we want to avoid, and then the quadriceps, also known as the suprapatellar fat pad, and the prefemoral fat pad, because between those two layers is the suprapatellar recess. And then with our target, we're going short axis to the quadriceps tendon. Again, we don't want to be long axis because then we're going to be going through the quadriceps tendon. And you're bringing that needle in plane from lateral to medial and in between the quadriceps and prefemoral fat pad. Now that can be very easy if there's an effusion present. That space is very obvious. But if there is an effusion present, then what you can do is once you're in the spot that you believe is the suprapatellar recess, you can inject anesthetic. If it fills in to that spot like the recess should, then you know you're in the right spot and you can go ahead and inject your steroid. So let's go ahead with the video here. So here I have the ultrasound probe in long axis, and on the far right of the screen or distal is the patella. And then we have to the left of it the quads or quadriceps tendon. And this is an ultrasound of my knee. So perfect. We've got this view. From here, I'm going to, in the next sort of clip, sort of identify the two fat pads. So we're sort of, here we are. And then I'm sort of moving my knee. And hopefully you can convince yourself that there's sort of two fat pads and they're moving slightly different to one another. We have the prefemoral fat pad, as the name suggests, just above the femur, and then we have the quadriceps fat pad just under the quadriceps tendon, and that space in between the two is the suprapatellar recess. Again, if there's an effusion present, really easy to identify. If not, you might have to do a little bit of that movement to sort of convince yourself where that plane is. So again, here just moving to sort of show that plane. Now, it's very important that you don't mistake, in this case, the hyaline cartilage, this anechoic structure, for joint fluid or joint effusion. Often you're not going to see this, particularly where you're doing these injections in individuals who are arthritic and don't have the same level of cartilage. So again, same sort of similar clip, there's the suprapatellar recess. So I've now identified it in long axis. What I'm now going to shortly do is I'm going to sort of switch to short axis. Certainly if there's an effusion present, you can just jump to short axis to begin with, but if there isn't, this is sort of what I'd recommend. So again, what I'm doing now is I'm rotating 90 degrees. And again, I'm moving the knee a little bit, and you can convince yourself there's sort of differential movement between two fat pads, and that's where the suprapatellar recess is. That's what I've identified with the red line here. And just to sort of identify some important sort of surrounding structures. We have our overlying quadriceps or quads tendon. Again, we really want to avoid that with our injection, which is why we don't do this in long axis. And then again, there is our overlying hyaline cartilage. That is not the joint. It is a joint effusion. It's not compressible. And then with where our suprapatellar recess is, which we identified previously, we bring the needle sort of in this track. And again, here I am moving sort of the muscle or the limb to just sort of show you where that plane sort of exists. Yeah, so I'm the neuromuscular mechanic, and I hope you found today's video series handy. Take care.